Welcome and hello to Delaware Health Forward, bringing you where healthcare is going in Delaware. I'm Wayne Smith, President and CEO of the Delaware Healthcare Association, and your host. Today's episode explores hospital at home and Beebe Healthcare's first in the state foray into this important new healthcare delivery model. I'm very pleased today to be joined by Dr. Lynn Voskamp, who's Beebe Healthcare's Vice President of Nursing Operations and Continuum of Care, Chief Nursing Officer and Administrator of Home Care Services, and Dr. William Chasnoff, Vice President and Chief Population Health Officer. Good morning, and thanks for joining us today.
Good morning. Thanks for having us.
You bet. So we will jump right in. And Lynn, I'll start with you. What's the Hospital at Home program, and why did Beebe Healthcare undertake this new initiative?
Yeah, Wayne, hospital at home programs have actually been around for 20 years or so. The problem has been there's not always been a payer mechanism for that. So in November of 2020, CMS actually issued a waiver for hospitals like ours to start a program. So that's exactly what we did. We completed the waiver, submitted that, had a phone call with CMS just to go over a few more of the details, although their application is quite detailed, and were approved almost immediately.
That's terrific. Congratulations on that. I know approval is not always the easiest step of getting a program up and running. Bill Chasnoff, on the surface, some might view this program as relatively simple. You're going to start caring for some patients at their homes, but there's a lot more coordination and planning involved. Can you explain what kind of work is needed to be done behind the scenes to make this idea a reality?
Thanks, Wayne. I can. It does sound really simple on the forefront, right? We do this. That's what we do in healthcare. We take care of patients. But this is a different format of where we're taking care of patients. We have some experience in home health, but this is different than home health, and I think that's a really important message. This is acute inpatient care that we are providing in the comfort of a patient's home. So I can tell this group that Dr. Voskamp, Lynn Voskamp, and I, and several others, we have been talking about this for several months before we really kind of drove forward with making this a true initiative. We did much research. We contacted many of the organizations that Lynn had mentioned have been doing this for several years. We went through the CMS waiver application, which again was a multidisciplinary team as we were presenting to CMS. We engaged, other executive leadership and leadership within our organization. So our chief information officer and his team, they were absolutely crucial, right? Because we're relying on technology to stay in touch 24/7 with these patients. We needed to make sure that our CEO and our COO were both a part of the planning of this process to ensure that this was in our strategic goals of what we wanted to do as an organization. Once we had those green lights and we had put a proposed plan together, really at that point, we pulled in the key stakeholders. And what I mean by that, Wayne, is that you don't think about the things that we do within the brick and mortar, every day, but we have physical therapists and speech therapists and occupational therapists. We need to ensure that we can provide, patients even in the comfort of their home, 3 hot meals a day if that's what they require. Social workers. So it's not just what people think are the doctors and the nurses. That entire ancillary and support system had to have a plan in case they were needed in order to see the patient at home. So I will say that we were pretty aggressive. CMS told us that it would probably take 6 months to put this program in place. I'm looking at Lynn. I think we did it in 4 months, and that's with a few weeks delay to make sure that technology was up and running, safe, and after several dry runs to ensure that we were able to provide the same level of service to these patients within their home as we do within the brick and mortar walls.
Okay, thank you. And Lynn, the answer to this question may not be obvious, but I'm sure our listeners and viewers want to know what are the benefits to patients who participate in the program?
Yeah, I think that probably the most important benefit is that people really do recover better in the comfort of their own home, their own surroundings, their own food, their own level of activity. So that I think is the biggest benefit. But the literature and those programs that have gone before us have also demonstrated that it reduces what we consider hospital-acquired conditions, such as falls, pressure injuries, and then overall, it reduces the cost of care.
It makes a lot of sense. And then, Bill, what type of services can a patient expect to receive at home under this program?
When pretty much all the services that we provide within the hospital, we have a mechanism to almost provide all of that within the confines of the home. We do have to be cognizant of the patients that we admit to this program. For instance, if we have a patient that we feel may need an MRI in the next 24 to 48 hours as part of this program, well, unfortunately, there's not portable MRI machines out there. So that might be a patient that we keep in the traditional brick and mortar hospital, just to make sure that we're able to provide those services that are potentially projected. But other than that, phlebotomy, nursing, physicians, providers, the ancillary services that I mentioned before, we have mechanisms in place to provide the majority of those services within the patient's home.
Okay. And not everybody, obviously, who's in a hospital traditionally is going to be a candidate for this program. Lynn, how would a patient come to participate in hospital at home?
Well, the way that they would participate, CMS is pretty clear as to how they can get into the program. So they either have to have been a patient in our emergency department and they meet criteria for admission, or they could already be admitted to the hospital and we can transfer them into the program from there. We also do have, and Bill maybe have mentioned this earlier, inclusion and exclusion criteria. So we do have a list of items in which will help us care for the patient at home in a safe manner. And so if they don't meet some of that criteria, then they really, it's really better for them to receive that care in the hospital. But they need to be either a patient in the emergency department or already on one of our inpatient units to enter this program.
And looking into the future, Bill, if a hospital at home works as planned and is fully implemented, what percent of patients, inpatients, do you see being treated at home through an initiative like this instead of the traditional hospital setting?
It's a good question, Wayne. We expect probably to be around 5%, and as the program continues to grow, hopefully even in double digits, closer to 10%. As Lynn mentioned, this is really about selection, selection, selection. We need to ensure that we have the right patient who qualifies for the service, and beyond just what services we may project they may need, we also need to ensure that they have other things. Social determinants of health is extremely important here to ensure that they have a roof over their head, right? I mean, that we're able to get into the home safely and that the patient has at least support, not necessarily someone who lives within the home with them, but some type of support to help them as well. So with that being said, even though selection is important, we expect 5 to 10% if everything goes well to be a part of this program.
Let me ask a follow-on question to that because you mentioned the case of somebody who needs an MRI during their course of evaluation might not be a candidate, but obviously over time, hospital equipment and technology is shrinking the size and making portable. A lot of instruments that used to require big rooms. I know, for example, in a hospital I recently visited, they bring the X-ray machine to you on wheels instead of having to be wheeled down. Do you anticipate technology being able to bump that 5 or 10% number up as it becomes more portable?
And Lynn, you can jump in at any time. One of the things that I believe that was surprising to me, and I can't speak for Lynn, but maybe it was surprising to her, is that the amount of tests, such as X-rays and imaging and ultrasounds, being arterial or venous ultrasounds, that actually can be completed with portable equipment in the home now. So if someone does need imaging, that actually does not necessarily exclude them from being at hospital at home, even if we felt that we needed to get some of that imaging, within 24 to 48 hours. But to answer your question, yes, I think as that equipment becomes more portable, and as long as it is efficient to give us the images that we need to make the clinical decisions we need to make, then I think it will just continue to increase the amount of patients that we can enroll.
The future is certainly exciting. Lynn, obviously, there's a lot of talk and focus on value in healthcare. It's something we deal with as policy issues all the time and are very focused on as an industry. Um, Focus on outcomes and quality of care is certainly a part of that. Uh, does this program deliver value, particularly when you add costs into the mix of trying to mitigate or minimize cost increases, or how does it?
Yes, it does, Wayne. When you are specifically talking about the value around dollars and expense, this hospital at home program actually helps to eliminate many of the fixed costs that we're accustomed to in the brick and mortar hospitals. Also, as I mentioned earlier, when it comes to outcomes and quality of care, there are studies from those that have gone before us that do demonstrate that you have fewer hospital-acquired infections because that patient is not in the hospital, around other patients and numerous healthcare staff. They really are those things are limited in the home, and then pressure injuries and falls and those other things that we carefully watch in our brick and mortar hospital. We tend to see less of those things at when the patient is being cared for in their home.
And this is not going to be a surprise because workforce is such a focus on us in the midst of the COVID pandemic in which we find ourselves. But workforce is an issue that always is attendant to healthcare, and particularly as we look into the future. What is the effect of hospital at home on workforce needs, both in terms of the actual number of people and healthcare providers needed, as well as the types of position? Is there any kind of change that this program engenders in that mix?
So Wayne, I can take that, and Lynn, please feel free to jump in.
Sure.
So we do have a certain core dedicated staff for hospital at home. Many of the ancillary services, Wayne, we basically have them integrated into hospital at home, so they have not had to hire new people, new workforce. We did recruit some experienced providers and physicians that were already working for Beebe Healthcare that had an interest in this program. So we have just taken a portion of their time from what they were doing before and have refocused to a project that they really feel is a fantastic project, which is nice because we all know that, in the mundane job that we do every day, if there's an exciting project that kind of gets us excited, it also recharges our batteries as well. So we have repurposed some staff to be core staff. And then we've also used our integrated ancillary services to basically be that support system that's needed for these patients. And I'm sure Lynn will have comments with nursing.
Yeah, and we'll just be through the use of technology, we're certainly able to engage social workers, case managers, some of those folks that normally wouldn't go into the home. We can still interact with those patients through technology. But as most people know today, nursing is certainly experiencing a shortage, and Bill talked about that a little bit. But it is concerning that it's going to be more and more difficult, probably over the next 1 to 2 years, to backfill the positions. These nurses that we have now are transferred from our inpatient units, and then we need to backfill those positions, and that is proving to be a little bit difficult right now.
Let's talk about feedback and what you're hearing. Lynn, I'll direct this to you first. What are the nurses saying? What are the patients saying? What are the folks who manage the program saying in terms of how it's working in the field?
That's a great question, Wayne. Our patients love this program. We have had nothing but positive feedback. And one patient went so far as to give us pretty detailed feedback about maybe some more consistency between the nurses and how they do things while they're in the home in terms of assessments. So that kind of detailed feedback has really provided useful for us. And then, of course, we depend on our staff to provide feedback as well. We do have frequent meetings where we discuss our processes and perhaps how we could improve these processes. And that's really what it's all about. You know, once we get that feedback from the staff and the patients, looking to see how we can improve. But overall, the feedback has been very, very positive.
That's great to hear, and I can only imagine as this is being rolled out, it's a tremendous learning opportunity for all of you who helped make this program a success. I'm sure the feedback is eagerly anticipated.
It is.
Bill, as we look to the future, what are BB Healthcare's next steps or goals as the program expands?
So our goals are to continue to expand the program, basically in our market share. Right now, we have our central location in Lewis at our Margaret H. Rollins campus. CMS has some detailed definitions of how quick we must be in a home if a patient calls. So we probably are going to look to see if we can do more of a spoke and hub model where we'll have touchdown spaces as the program grows to expand through areas that we're covering in, further Sussex counties, such as Bethany and Millville area as well. So we hope to continue to expand this to our community and make this, make this really a program that can be offered to many more and open it up to many more people. So that is one of our big goals from there. The other piece is, we had mentioned before that we know this from home health. It's always a privilege for a patient to allow us as healthcare workers or anyone into their home. It is it is sometimes absolutely eye-opening to see what type of things that we can help with besides just medical care when they allow us into their home. And again, not to harp on social determinants of health, but how important it is to actually see how people live. When they're in the brick and mortar, we all do it. We all make assumptions, right? We all make assumptions of how people live, and people have food in their cabinets, and they have transportation, and they have, a stable roof over their head. And we all know that that's not always the case. So we hope to expand, in addition to just the program, to see how we can tie in some of our outreach programs, our population health team, and really how we can try to improve the health of Sussex County with programs like this.
Yeah,
And
that's a
if I
really interesting. Oh, I'm sorry, Lynn, please.
Yeah, and I just want to add just one comment. I think the other thing that it's done for us, for me in particular, is it's given us the opportunity to really consider how we can use this similar technology of this command center and this technology on our inpatient side.
Mm.
Um, and because, as we mentioned earlier, we know the nursing shortage is only going to continue. So, is there a space on our inpatient units where we can use similar technology and this virtual nurse sort of in the background that's guiding the nurse that is directly at the bedside? So I think it just opens up really all kinds of opportunities for us to use more technology for inpatients.
That's a great point. It's almost a value added feedback loop that might influence how you deliver care in the inpatient setting through lessons learned. That's going to be exciting
Right.
to watch. And Bill, the point you made about social determinants of health is obviously so important and such a focus as we begin to understand more and more the impact that someone's social determinants have in the life that they live on their health. I can only imagine, I would guess, that you're in a position to find out a lot more about people and their needs because you're in the home than you get through a traditional hospital survey with an inpatient person.
Absolutely. I mean, again, it's a privilege. It's a privilege for people to allow us into, to their comfort zone where they live. And, some of those hospitalizations, Wayne, right? The example that Lynn is probably tired of me talking about is the patient that keeps getting readmitted for heart failure. And we go into their home and we see that they're eating cans of Progresso soup. Nothing wrong with Progresso soup, but we all know it's high in sodium, right? And these triggers that we can educate while we're there that we wouldn't be able to potentially identify when they're in the confines of the brick and mortar. So there's a lot of opportunity here. And we feel very privileged to be able to provide this service.
Lynn, Bill, let me ask if there's any, oh, I'm sorry. Let me ask if there's any final wrap-up thoughts, anything I haven't asked or any points you'd like to make sure our listeners and viewers are aware of?
Well, I can just say we're certainly honored to have been the first hospital in Delaware to stand up this type of program, and just a thank you to all of the key stakeholders here at Beebe that have worked with us to get this off the ground. We do believe this is going to be really going to carry us way into the future. Technology is going to be where it's at. We know that our workforce is shrinking to some degree, and we really have to leverage that technology.
What's exciting? It's certainly this is great news for patients, exciting for patients, exciting for Beebe Healthcare as you venture down this road. Please keep us apprised of how this is developing, and I think certainly a look back in the future in terms of lessons learned and where the program is would be a very valuable thing to bring to our listeners. So with that, Dr. Lynn Voskamp, Dr. Bill Chazanoff, I want to thank you very much for taking the time and sharing with our audience this very exciting new foray for Delaware. Thank you much.
My
Thank you.
pleasure. Thank you.